Chat already. Okay, we are going. Okay. Hello, everyone. Welcome back to another session of Virginia Shadow. Today, we're joined by Dr. Jay, who is a pediatric dentist and also a professor in Virginia Commonwealth University. And thank you for joining us. The floor is yours.
Thank you, Scott. Hi, guys. Scott, is there a way to see how many of them are currently online?
I will be checking the questions on there, and I will send the questions to you later.
Okay, that sounds good. Awesome. Hi, everyone. I'm Jay. Okay, let's see. So this is the template that was given to me. I was trying to as much as comply with the templates, but sometimes it might be a little out of order. I'm Jay. I'm an associate professor and director of research in pediatric dentistry at VCU School of Dentistry, Virginia Commonwealth University in Richmond, Virginia, United States. So I have quite a diverse background in terms of my education, as you might see here. And I'll get to that in a bit. I also work as an associate pediatric dentist in a private practice, not too far, about like 60 miles from Richmond, Virginia, towards the beautiful Virginia beach side. So that's where I do one day of my private practice, and the rest of the time I'm a full-time faculty at the VCU Dental School. So this is my story. As you see these little dots in this world map, I did my dental education from basic dental degree from India. And then I went to Hong Kong, where I obtained my master's degree and residency in pediatric dentistry about 12, 14 years ago. And I continued doing my PhD with a collaboration in England at King's College London. And then I went to work in Malaysia for a while. And then I decided to move to the United States, and I had to do my second residency to be able to get my credentials in the States. As you might know, it's kind of a tedious process. So I moved to US. I did my residency in pediatric dentistry at UT Health San Antonio, Texas. And after which I came to Virginia to continue my academic career here. So that's a little bit about my education. And as you see these little green dots everywhere, I'm a pediatric dentist, but I've been quite active in academia and research. I do have established research collaborations pretty much in all the continents, I would say, as you see here. That's been something that I've been doing for over 10, 12 years. So I'll get to that in a bit. But otherwise, that is my long journey short. I'm an international candidate when I moved to the US. And if you have any specific questions, let me know. I'll be happy to share. I didn't do my IDF program because I was already an established pediatric dentist with a lot of research interest and quite a prolific background in research. So I skipped that part and I directly got into my residency, after which I was able to get my dental licensure and be able to practice independently. But I pretty much chose to be in academia because of my interest in academia. I love to teach, I like to do research. So that's the reason why I still chose to be in academia, but also you can't teach what you don't practice, you know. So that's the reason why I do one day of practice, just to keep up the clinical skills, you know. So as an international candidate, it's always been challenging because there aren't many schools that I could initially apply to, and I was very particular about applying to pediatric dentistry. To me, is that it's no way I'd be able to do general dentistry again. It's like a funnel, you know. You move from a general dentistry perspective all the way, and then I did a pediatric dentistry residency, and a long time back, and then I focused on my research, and I funneled. The funnel was quite narrow at the time when I don't want to go all the way back to the base of the funnel to do my general dentistry again. So I just applied to pediatric dentistry programs. I did have some connections by the time, pretty much from my academic background. So I was able to connect with people. So whenever I came here, I do come for conferences for a while, and then I kind of got in touch with these program directors and expressed my interest in moving to the US, and that's how I established the connection. And then I went through interviews and a couple of programs. And if you, as I know, this presentation is pretty much to give a little bit about my background in terms of my academic career into the US, but mostly to educate you all with a little bit of pediatric dentistry in a different perspective, So it was quite, I wouldn't say it was impossible, but it was difficult. As you know, with any international candidates, there were a very limited number of schools that I could apply to, and you got to play your game fairly, but it was quite easy for me because I had interest in academia, and I was upfront. I told them I want to be in academia. I like to teach. I like the US perspective. I want to come here. I want to get my residency, and I want to teach. And as you know, that pretty much 30-40% of faculty positions are still available in the US. No one wants to take an academic position. So they find me like an interesting candidate because I express that clearly. And I am still sticking to that promise because I like academia. So what worked for me, this is another little bit of a tidbits for you guys. If you're aspiring to become a dentist or a pediatric dentist in the US, as you all know, the requirements was, at the time was NBD. I had to fly to the US twice to take my part 1 and part 2. Right now it is integrated, but at that point of time, there's 2 different exams. So I had to come at 2 different time and take those exams. TOEFL, somewhere around 100 is a decent score, I would say. The most important thing is a good personal statement. So be very open and honest about what you want to do and just express it clearly in your personal statement. I think it's very important. And US works so differently, particularly as an international candidate. It's so difficult to kind of even establish the connection. So you need to know the people, the right people. There are different ways of getting to know them. Very rarely the email. Right now I'm being a faculty. I receive like tens of emails every day asking for me like what to do, what not. But I respond to each email. Okay. So, but sometimes they are very busy. I do know academia is really, really challenging. So they seldom find time to kind of even respond to the emails. So don't be upset if you don't receive any response. Just send a kind, gentle reminder once in a while, and whenever they find time, they would get back to you. So that's my thing. So familiarization is important. And once you're after the interview process, your selection through a match process is very important. So most of the schools work differently, but at least with UT San Antonio, they had a pre-match position, match, and a post-match. So if they really find that you're an amazing candidate, not necessarily, but if they find that you're good enough to the program, they would offer you a pre-match. And sometimes and then you go to the match process. So it depends. They say that it mostly favors the candidates for the match process. But if you have to kind of go with your gut feeling, how the interview went, what the kind of little bit here and there, the cues that you get out of the interview, that would really help you. So match process is a very important thing on how you rank the programs, So after that, as an international candidate, I had to take a licensing exam because that's the most important. As you know, there's different regional exams that you could do. I took a REB exam based in Texas. And then I was able to get my dental licensure. And as a pediatric dentist, you need a moderate sedation permit, which again, it's incorporated into the program. But you need to separately apply with all the requirements and letters indicating that you have the education for obtaining a moderate sedation permit. And the most important thing I would say is choose the right workplace, some place that you can grow. You see an opportunity. I had a couple of interviews in fairly good amount of programs, and I chose to work at VC because I felt that it's the right place, and I still think that it's an amazing place to work. I have a good, very good, nice colleagues and an amazing set of residents that I interact with. So it's a great place to do. So when you choose your workplace, whether it's in private practice or academia, choose a place that works well for you. Okay. So that's my little bit of introduction about, my suggestion about getting into the US or doing something related to your specialty. So this is a question that I was asked, and I just put the question in and so that it'd be easy for me to kind of answer to the specific questions. So one of the questions was what factors did they consider with specialties? So even now, a lot of my D3, D4 students contact me and ask me, like, what do they actually expect in a pediatric dentistry program? I'm in the committee for residency interviews, and I do conduct interviews as a part of the team. So the most important thing is that we see how much interested you are in the specialty. So you got to be very clear that at least with pediatric dentistry or any specialty, that this is what you want to know. This is my heart, soul, everything. So that's kind of the projection that you need to give when you are being interviewed, when you express your interest, or even when you contact people. So there are different ways of doing that. You can associate with the school like the pre-doctoral dental societies, pediatric dental societies, or any specialty of that for that matter. So have some work experience. It could be either volunteering, not necessarily volunteering, but shadowing or kind of working with someone who you know on summer. Just work in a pediatric dental practice. You don't need to necessarily do anything, but just be around, see how things are done, and get a recommendation letter from a dentist whom you work with. Even it could be like working on the dental softwares, even cleaning up materials, anything it could be, but it still adds because it shows that you have an interest and you have worked with in a dental setting. Research, it's not a great thing, but it would certainly add a lot of value because, again, it depends on the program that you're applying to. Some programs are very strong in research. They expect the residents to do research. So I would say that it's not that very important, but again, as some programs are master's program, it comes with a mandatory master's. Some are certificate programs with just a residency. Those programs which has a master's as an integrated component, compulsory component, you have to do a thesis and defend your thesis. So although most of them would want to be a clinician, but it's still a requirement. And I see some of the residents, they kind of have a little bit of resistance towards doing research because they think that, it's not required. I'm not going to do research every time. But again, it's a part of the program and it's important for you to graduate. So you have to do it. So even if you establish something like some research, even basic stuff, like even a case report, poster presentations, or anything of that sort, to indicate that you have some inclination that you can just sustain 2 years and do your research, that adds a lot of value to your application. Volunteering, if you have done any volunteering related dentistry or even non-dentistry, just to show that you care for the society, So that is to some extent important. Recommendation letters. You need to contact the right people. You need to get the right recommendation letters. So that carries a lot of value because sometimes we get recommendation letters from most prominent people in the specialty, which makes sense because to get a recommendation letters from such a big personalities would indicate something that this candidate is really good. So we would certainly work considering them, at least call them for an interview to see how things are. All right, so the second question is, what is something that they had trouble with? I'm not sure whether I didn't really understand the question, but what I believe is that what is something that I had trouble with in choosing the programs? So first and foremost, it's a tuition. So I think that some of the programs are exorbitantly expensive. Some are reasonably good. Some they don't even charge tuition. So most of the hospital programs pays you well in terms of stipend. Most of the university programs, because primarily it's a university setting, so they may not offer you much of a stipend. But then what you need to look into is a balance between tuition and stipend. So sometimes you get a huge stipend, but the tuition is as equivalent to your stipend. So pretty much you use all your stipend to pay your tuition. So that doesn't make any sense. So that's something that you need to look into. If you're interested in pediatric dentistry, there is a website. You go to AAP, Google, type AAPD, which is American Academy of Pediatric Dentistry, and type AAPD residency. And the first link that you would get is a page that contains all the programs that offers pediatric dentistry in the US, which has all the information. They have done a beautiful job in putting all the information together. It says clearly that if you're an international candidate, are you allowed to come in, or do you? What is the tuition? What is the stipend? How many full-time faculty? How many part-time faculty? How many of them are board certified? And you get all the information there. So if you are interested in pediatric dentistry, I strongly recommend you start from there, go to AAPD website and look for residency programs there. So the things that I was looking at is like a well-rounded program, which means that some are good at something, some are different than the other. I mean, others are, different in specific things. Like, for example, in pediatric dentistry, things that we look into are, sedation, for example, sedation experience, interceptive orthodontics. Pretty much all the programs teach you basic bread and butter pediatric dentistry, but is there anything else that they offer in addition to that? So that's what that you need to look into. If you're interested in research, there are programs with very strong research. So those are the things that you need to consider. All right. Another question, is there any specialty that you would have considered or would consider? Of course, yes. I'm a pediatric dentist for over 10 years. So initially when I wanted to come to the US, I was kind of looking at why should I go and learn the same things that I already know, So I was inclined towards orthodontics or oral surgery, but then again, it's to set foot totally in a different specialty is very challenging. That too when you're coming from a different country. I know a lot of few of my residents and some of my friends have done one specialty and they have done another specialty. So they're pretty much like a dual trained ortho pediatric dentistry, oral surgery pediatric dentistry, endodontic pediatric dentistry and stuff like that. But for me as a foreign trained, it was difficult for me to convince like I want to do a totally different specialty. So I did contact few, and then I got a response and I found that it is not worth doing that. So, and that's the reason why I just stick to pediatric dentistry and then apply to those programs. I got an interview. So if you have any questions specifically about what programs that I was interviewed, or any tips that you need for you to kind of help with your application, shoot a message in the chat section and I'll contact you and I'll let you know. Alrighty. So what makes you a better applicant? So my first and foremost thing is honesty. Just be very honest, be clear what you want to do and why you want to do it. And reflect that, as I told you, in your statement of purpose. If you want to be in private practice, be very clear about it. If you're in academia, just mention that. If you want to be in pediatric, why you want to do a specialty, just clearly say why it is. Like, is there any experiences that made you strongly feel about a program? Indicate that in your statement of interest letter. Very important. Determination. That's, as you all know, I'm not sure how many of you are dental students here, how many of you are planning to a residency, general dentist. I don't know that, but I can tell you wherever you are, whether you want to get into a dental school or if you want to go into a post-doc program, determination is very important. So sometimes you may not get at your first try, so you got to wait and try again and again. Sometimes you may get in the first time, sometimes you get in the second, sometimes you may get at the fourth or fifth attempt. But all I can tell you is that it is worth doing at the end of the day. Even after a couple of attempts, once you get it, and then you know it was worth waiting and worth applying again and again. That much I can tell you. A little hard work is good enough. You need not be like a super hard worker and do a lot of background things. That's not required. But just do a little hard work. That's good enough. And always, as you know, don't hesitate to take risks. So if you wanted to go visit a program, if you want to shoot out an email, if you wanted to contact someone, you might feel like, oh, I'm just a first-year dental student. Why should I express my interest in doing, for example, a specific specialty? Oh, what if I write to this professor and he doesn't even reply? Or what if that? Don't hesitate. If you just do it, it is okay. You may not get a reply. You shoot out 100 emails, you may get like 2 or 3 is back. But even those 2 or 3 emails are worth. I've always had this habit. Anytime I come to US, even when I was not in the US, wherever I go, I have a habit of meeting people and going to schools and even establishing connections. Even now I do that. Even although I have my job and everything is settled, but I still go and meet people wherever I go. To go to dental school, say hi. It doesn't take too much time to go and say hi to them, but on the long run, it makes a lot of difference. So keep that in mind. Just don't hesitate to take a risk. Anyway, so what a typical day is like a faculty. So I have kind of, since I have my private practice, I work as a pediatric dentist, and I also am a faculty in a pediatric dentistry. I thought I'd just give 2 different perspectives of my working work days. So as a faculty, I work 4 days a week. most like 2.5 days or 3 days I teach. I mostly teach my residents or postdocs. Sometimes, very rarely, I do pre-doc teaching. So at the VCU Dental School, Pediatric Dentistry, it is in the Children's Hospital of Richmond. It's within the hospital system. So we run the space, and we have like 5 operating rooms and 6 open bay chairs. There are about 12, we have 12 residents in total, 6 per year. It's a 2-year program, 2 interns and 1 fellow currently. We do all kind of dental, on a typical day, we do like initial visits, recall visits, restorative extraction procedures, 1 or 2 sedations, or even 3 sedations a day. For half a day in a week, we have didactics. So I do current and classic literature reviews with my residents. I do like treatment planning sessions. I bring up like cases that we have treated so that everyone can learn, they can give their input. So I think that's more like like an OSCE style kind of learning. Sometimes residents present seminars, or sometimes I do seminars. Sometimes I give them a small test just to test, like just to test like how much they know about certain topics once in a while. Once in a week or a fortnight, I go to Children's Hospital, the operating room, to teach my residents on how to do patients in the operating room setting. We roughly have about 3 or 4 patients per session. So this is our pediatric dental clinic. On your left is your open bay, and to the right is the treatment room. As you see, we have like the if you're doing a sedation, we have all the monitoring instruments over there. We have, for distraction purpose, we have a TV screen that you can play their favorite things. And we also have a nitrous unit, which is like attached to the system. All right. So what is a typical day like a pediatric dentist? So in my private practice, we have around 2 operating rooms and 3 open bay chairs. I have 4 dental assistants and 2 front desk staff. As pretty much with any dental clinic, we have like initial visits, recall, operatives, and sedation. The most important aspect is challenging thing is with the insurance, because most of them are Medicaid, some of them are private, but the front desk people pretty much know how to handle those things. So that's not my thing, but that sometimes can be challenging, because every time you do a change in the treatment plan, you have to let them know, because they should be aware of what they will be paying. Like either it's a copay, or if it's insurance is covering completely, that's well and good. Or sometimes I kind of, if they're private insurance or from the patient pocket, then it's got to be like a little pricey. So they need to be aware about those things. So I also do private, operating room procedures, probably once in a month or something like that. So we have a surgical suite, and 1 front desk staff, 1 dental assistant, 2 nurses, and anesthesiologist. So we need to have an anesthesiologist to kind of give a deep sedation or general anesthesia to the patients. It kind of goes on and off. So we do a pre-op, and then we do the treatment, and then post-op, and then it goes like a cycle. So we have a couple of patients to treat every day, at least double of what I would supervise with my residents. But when I'm all by myself, we got to be really fast and efficient. So it kind of goes on and off. So that's my operating room schedule in my private practice. So that is all with my background. So let's jump into pediatric dentistry. So I have just looked into, there's a lot of pediatric dentists who have done a presentation with you all. So I was just wondering, like, what is something that I can do differently? I just don't want to do the same repeated stuff. But I have come up with some interesting cases for you to learn. So which will be quite interesting, I would say. So pediatric dentistry is an age-defined specialty, as you all know. Some school, although it's like an age-defined specialty, some schools, they have restrictions, like some, they don't see anyone over 14 years or once out of the permanent teeth or in. Some places they set like until 18 years, or some schools they don't have any age limit, even like if there is any special need patient, children with special needs, or even adults with special needs, they are still more seen in the pediatric dental clinic because of the behavioral issues. The most challenging part with pediatric dentistry is the behavior management. So that's the reason why most of general dentists, they don't want to see kids in the clinic. They wanted to send a referral. And that's when we jump in, because we are trained in behavior management, different, whether it's a pharmacological, non-pharmacological. If it's a pharmacological, it could range from mild anxiolysis or nitrous sedation or nitrous oxide, or even to moderate sedation. So that's the thing. Prevention is a very important aspect in pediatric dentistry. So we emphasize a lot on prevention. My practice primarily emphasizes on prevention. So I go through with patients with anticipatory guidance and keeping the teeth clean, trying to avoid having new cavities and things like that. Restoration, that's a common thing. Resin-based restorations, glass ionomer-based restorations, stainless steel crowns. Those are the things that they usually do in any private dental practice. Rehabilitation, we don't usually do partial dentures for primary teeth, but then mostly with space maintainers and stuff like that to be able to allow the teeth to come in a proper position. Some of the cases, complex cases, require multidisciplinary approach. For example, like it's like an impermanent tooth or any oral surgical procedures and things like that. So I'll get to that later. So that's kind of pretty much with pediatric dentistry, and sometimes with trauma, those managements all requires multidisciplinary approach. So as I told you, most of the kids come when the kid come with a lot of dental caries and stuff like that, we do what we call as a full mouth dental rehabilitation, requiring restoration, extraction, pulp treatment, space maintenance. Those are the things that I told you earlier. Orthodontics, we do phase 1 orthodontics, which means that you do just mild corrections. We don't do full mouth braces, but then some mild corrections arch expansions or correction of cross bites and stuff like that. Children with special health care needs are very important, because there are a lot of children with a lot of syndromic conditions or complex medical conditions. So we communicate with the medical doctor, their primary care physicians, to get some consults to see what is the best way to approach or manage those children. Dental trauma, primary teeth, permanent teeth. So we have we work out of the Children's Hospital. So our residents go on rotation with after work dental trauma management. So whoever faculty who's in charge, we contact them, they contact us, and so we kind of provide them with management of dental trauma, or even any emergency medical or dental conditions. So oral surgery, again, this is not usually taught in pediatric dentistry in the United States, but since I had quite an amount of experience outside the US, so I honed my skills in oral surgery. So I do a bit of oral surgery, which my presentation is based on. I'll be discussing about 3 or 4 cases of oral surgical procedures that I performed on pediatric patients. But that's again one of the subspecialties that I would say. So as I mentioned earlier, we have 30 minutes. Pediatric oral surgery. So I have got 4 cases with very interesting titles for all 4 of them, just to keep your thoughts stimulating. So the first patient, first case I would say, is a child with a locked tooth. So what do you think about locked tooth? Which means that the tooth either did not erupt properly or something of that sort, right? So let's look into it. What is a locked tooth? So this is a case history. It's an 8-year-old boy. Yeah. He was vacationing in Australia. He bumped whilst playing, and he avulsed tooth number 8 and 9. So it's outside the US. I had difficulty with the tooth numbering system. So it's pretty much like 1-1 and 2-1. That's what he said. But in the universal tooth numbering system, it's 8 and 9. So 2 central incisors. So they had difficulty identifying a dentist because they're from the US and they're vacationing in Australia. So they finally found the hospital, and they were able to splint the tooth back, put the tooth back into the socket and splint it. So the child got back to the US, everything seemed to be fine. But after a year, they found that one of the tooth wasn't able to kind of come out. It was kind of locked in. So that is the intro photograph that you see. you see the infraocclusion of tooth number 9 by around 2 millimeters. So that is what you see here. So we took a radiograph. Again, we found that there is a pulpal necrosis of tooth number 8, and which is diagnosed with apical periodontitis. And tooth number 9, as you see here, was ankylosed. Try to make this one here. So you see here at this red spot, there's like the pedial ligament is missing, which means that it's kind of replaced with a bone, so which resulted in the ankylosis of tooth number 9. And when there is an ankylosis, the tooth would not have a normal percussion. It has a kind of a metallic percussion, you know. It wasn't that obvious, but I was able to at least compare with 8 and 9. There was a little bit of metallic percussion to number 9. We did a EPT on 9, 7, and 10, which are the lateral incisors. Everything seems to be fine. Okay, so I'll move it back here. So the treatment plan was to do a moderate sedation, raise a flap. It's a papilla preservation flap, which goes like horizontally across the attached mucosa, above the attached mucosa. Non-surgical root canal treatment of tooth number 8, and do decoronation revascularization on tooth number 9, which means that you leave the tooth number 9 inside to be able to maintain the bone width. So in the future, you can plan an implant so there is no bone loss related to tooth number 9, you know. So that's called root submergence or root burial, or anything on those terms. And for replacing the tooth, we planned on doing an interim partial denture with an acrylic tooth, and then later on do a fixed retainer with a natural tooth, and then keep calling it back over. All right, so that's the interim partial denture we constructed. So how do you plan that? Because we removed the tooth, we planned when the impression was taken, before the decoration or cutting the crown, but in the impression model, you can mark it, and then we knock the tooth out in the model, and then we put this acrylic tooth with retainers. So that's the day of the procedure. You see, he was sedated, and my friend, endodontic resident, did the procedure. I was monitoring under as well as I was assisting in the surgical component of the procedure. So he was 45 kilos. If you know what these medications are, meperidine is a narcotic, and hydroxyzine is like it's an antihistamine. So we dose calculate. Always you dose calculate based on the weight, and don't exceed the max limit. So for his age, so the max limit is 50 milligrams of meperidine and 25 milligrams of hydroxyzine. Hydroxyzine we kind of give it to compensate the effect of narcotic or meperidine, which is a different topic altogether. I don't want to get deep into it. So we give a little bit of hydroxyzine to counteract the effect of meperidine. So nitrous oxide kept at 50%. Sometimes I give start with 100% of oxygen and slowly go titrate down to 50%. And we gave 2% lidocaine as an infiltration and an acetylpalatin block. All right, as you see here, this is like a papilla preservation flap. The marginal papilla is remained intact. You go in the attached gingiva, a little above the attached gingiva, make an incision, go around, and then you trim the tooth, pull the tooth out, and leave the little bit of the root in there, and then you put the tooth back and the flap back and suture. So that's a papilla preservation flap. Sometimes there's a full thickness mucoperiosteal flap, which I'll be discussing later on with another case. So this is what we did. We left this small root inside, as you see that this is the pulp chamber, the root canal. And then we put the flap back and sutured with 4-row bicryal, which is like a resorbable suture. And this is the post-op radiograph. And yes, we did the endo resident did the root canal on tooth number 8. And that's what the apical puff looks like because of the infection. And this is the leftover root. So it's called a root submergence or root burial. And it's called decoronation when you cut the crown. So that is what we did. So this is a partial denture. As you see that, it fits quite well. So we gave the denture just to maintain the space too for his studies. He's a teenager, he was about 10 or 11 years old. We don't want him to walk around with the other two. So we prepared this ahead of time, so we delivered it to him. And that is what it looked like with a partial denture. And then we decided the knocked out tooth, which is a natural tooth, we decided to use that tooth to kind of plan a fixed retainer. It's kind of a very innovative approach because it's very difficult to attach a natural tooth with an acrylic material, So it's basically remove the pulp, clean it up with hypochlorite, and then dry it, and you fill the pulp canal with a resin of choice, which is A2 shade here, and then this is the bands for the fixed retainers. As you see here, we did a little bit of retention grooves, so this would help to attach with the acrylic denture. So retention. This is a natural tooth, by the way. This is the original real tooth. So this was done, and then what do we do next? So this is the fixed retainer with the natural tooth attached to the acrylic. So we left a little bit of an omega loops there, which helps to expand because he's still growing, he's still in, his jaw grows, so when it grows, this omega loops helps to kind of a little bit go adjust with the growth, and we can just do a little bit of an adjustment there to compensate his arch development. All right, so that is what it looked like after we gave it. It was a little white in color because it was dehydrated, but after a while, after we inserted it, after 2 weeks, it looked pretty well matching, So that is the fixed retainer with the natural tooth. So this was like a pre-operative. You see that the infraocclusion, this is the same tooth that we knocked out and put back into original place with some retainers. So that's the post-operative photograph. And as I told you, the tooth was a little blanched, I would say, because it was like, we still did put it in the water, but it takes some time to absorb, but it did change color after a while, say that. All right, so that's the first case. The second case is kissing canines. So as you pretty much know from this topic, so canines usually like that. So what is a kissing canine? How can a canine kiss unless until it goes like that, So that is what I'm going to talk to you about. In this case, we have 20 minutes. Got it. So 14-year-old girl, this patient was treated when I was during my residency in Hong Kong many, many years ago. I'd say 10 years ago, I'm talking precisely. So a 14-year-old girl with missing permanent canines. She has severe crowding. She has a class 3 skeletal malocclusion. So you know what's a skeletal class 3? That's the radiograph I was talking about. Kissing canines. You see that the canines are horizontally impacted here, pretty much touching each other, almost there. And there was a little bit of a rotation on his incisors because of the malpositioning of the thing. But one good thing that you notice here is that there is one retained, So one thing that you see here is this is lateral, central, lateral, premolars. The premolars are all well aligned. So when we actually look at the clinical photograph, you wouldn't be able to see even the canine is missing, But it just came to the thing when we took a radiograph, it's like, oh gosh, this is really horizontally impacted. So this is a Cbct scan. You see how it is. So this gives you a very clear picture of the tooth in 3 dimensions. 6 was buccal to number 7, and 11 was buccal to number 10. But it is kind of a little bit very odd shape. So this CBCTs usually take before doing any surgical treatment because it gives you a clear indication of how you would extract the tooth. In this case, if you wanted to go ahead and remove this tooth, you see that it kind of has an overlap. So you probably have to section one of the tooth to remove it because you don't want it to interfere with the adjacent incisors. All right, so what we did, this is a lateral cipogram. These are the different numbers. The one that you see red in color means that they are like really off the limits. It's like at least 3 standard deviations off the normal limit. So I wouldn't say that there is maxillary hypoplasia. Her SNA looks fairly okay, but her SMB, which is SNA is more like maxillary positioning and SMB is mandibular positioning. But you see his mandibular positioning is way off from normal, which means that she's got more of a prognatic mandible, kind of projected way ahead. She's got we call this like mandible grows like faster, So anyway, faster and longer, I would say, because it's like way down. It's called like vertical growers pretty much. So it goes downwards and more forwards. So that's a skeletal class 3 malocclusion. And that's the cephalometric tracing, as you see that the mandible is way off from maxilla. All right. So the problem list, we consulted with the oral surgeon orthodontist, of course, because she has a class 3 malocclusion and she's got a severe crowding. I'll show the photograph in a bit. And horizontally impacted tooth. Then we decided to remove the 6 and 11 because it's not because it's kissing, it's just because that she's going to do a lot of tooth movement and it's going to interfere with the movement of the incisors because she's going to go get a bilateral sagittal split osteotomy of the mandible to put the mandible back in position. And when we do those phase 1 orthodontics, it might interfere with her tooth movement because it's just, the canines are just sitting on top of the root of the incisors. So that was the treatment plan, and then do phase 1 orthodontics to correct it, do a sagittal osteotomy of the mandible, and then do a phase 2 orthodontic to kind of correct everything in place. Well, that's the surgical treatment we did, as you see here. This is like a full thickness mucoperiosteal flap. This was done under general anesthesia, of course, because of the intensity of the procedure. So we did a full thickness mucoperiosteal flap probably from the second premolars to the second premolar, and then trim the bone above the roots, and then as you see that the socket is clear, and then we remove the tooth. So as you see here, these are the 2 sockets where the canines were, and we put back the flap and suture tightly. So as you see that the flaps are all beautifully done in place. It's called simple interrupted sutures that you go from buccal to palatal and secure those flap in position here. So that is the CBCT image that I showed you, 2 canines, and this is after extraction as you see here, prosection to avoid damage to the adjacent teeth and to extract it without causing any problems. So that's the post-op photograph of the extracted canines. So this is the follow-up. I think it was taken a year after. You see that the gums are well aligned. Of course, there's a little bit of inflammation owing to her orthodontic treatment, but it did quite well. And she was undergoing phase 1 orthodontic treatment at the time. And she will then, as you see, the class 3 is not yet corrected. They will do a sagittal split osteotomy and then do the corrections afterwards. So it's a bit of a lengthy work, but we did the first part of removing the hindrance, which is the canines, to be allowed to even allow this tooth movement to occur. If you had left the canines there, we wouldn't be able to even move the tooth around. All right, so that's done with case 2, and case 3, we have 13 minutes. Partners in crime. So this is a 12-year-old girl. Again, this was treated in Hong Kong. She came for a routine dental exam, no problems at all. She was clinically caries-free. There was mild crowding. And then on a routine radiograph, we found that there was some mesiodense in tooth number 59, which is above the tooth number 9. So what you see here is you see a 1 supernumerary or mesiodense, which is inverted between 8 and 9, right? So I believe that you all are able to see that. You see 1 supernumerary. Am I right? Okay. So and then you need more radiographs because you can't totally rely on a panoramic radiograph to see what is happening. 1, because of the central trough. 2, because you are looking at a curved object, the curved arch in a straight image. So there could be a lot of distortions. You always take an additional radiograph. And this is what we found in additional radiograph. There was an extra supernumerary tooth. So 1 was in the mid palate, as you see here, and 1 was above the root of tooth number 9. An additional information from this radiograph is tooth number 9 has dens invaginatus or dens indente, as you see here. All right. So this is again a CBCT to help you plan your treatment quite well. As you see, 1 supernumerary was close to tooth number 9, and another one was in mid palate. So the problem list was she had 2 supernumerary teeth, 1 located in palatal and 1 in the mid-palatal region, or 1 in number 8 next to number 9 and 1 in mid-palatal region. So we decided to raise a flap. So when you raise a flap to that extent all the way to the back of the molars, you always prepare an acrylic stent because what happens, the blood pools down and it forms hematoma. So it's always good to do a acrylic stent which holds the flap in position. So we took an acrylic stent ahead of time. So this is what the thing. It's a basic thing. It's like a Adam's clasp and some ball clasp, and we took an impression and created this, and we delivered it immediately after the surgery. So we did a nasopharyngeal nerve block and a little bit of a greater palatal nerve block. You have, as you know, the greater palatal vessel comes all the way opposite to the first or second molars and go all the way here. And the nasopharyngeal nerve then comes out of here and it supplies pretty much the premaxillary region. So give a block, nasopalatin as well as the greater palatin, and raise a flap all the way from premolar to premolar. And then, as you see here, this is a socket that one supernumerary was removed, and this is another one that you see here. So, and then put back the suture in place. This is what I was talking about. When you raise a flap to this extent, what happens is that the blood gets pulled here because of the gravity. So the stent would keep that in position. So we did give the stent to her, and this is extracted supernumerary teeth. And this is a follow-up after, I think after a month. You see that the soft tissue healing was fantastic. There was no other problems. Her recovery was quite well, I would say. Her oral hygiene was also fairly good. So that's the end of the case 3, and this is the last case. We have another 10 minutes to go. I came with some interesting Hispanic, Spanish word, tengo hambre, which means that I'm hungry. So I'm going to talk about this very interesting case. We have dealt with all like adult patients, 13, 14, 15-year-old. Now I wanted to give a perspective on the life of a pediatric dentistry. I'm going to talk about a case of a 3-day-old infant. She's just born, little baby. So this was done in our pediatric dental clinic at VCU Dental School. I was supervising my residents to do this procedure. So 3-day-old infant, it comes all the time. 3-day-old infant. So she was unable to latch for feeding. So basically the pediatrician determined that she had a tongue tie and she was hungry, which is hambre, and then not being able to feed. Mom was upset, and the baby was constantly crying because I'm not able to latch, not able to be just normal, was hungry. So she was referred to us for tongue tie release. So this is the photograph, as you see here. It's called ankylosing. The tongue, these are the little mucous salivary glands you would see in a very infant babies. And you see that the frenal attachment goes all the way from the floor of the mouth all the way to the tongue. It's very difficult to take photo on a 3-day-old infant when she's like literally crying, but this is the best that we could do. So the challenges in this is kind of quite interesting things that I emphasize even to my residents. There are certain things that you need to know when you are handling, whether you're removing a natal tooth or whether you're doing a tongue tie release or anything. You have to always look to ensure that the baby had taken a vitamin K shot. Okay, so what I mean here is that the babies, they don't have enough vitamin K. So vitamin K is very important for the healing process, So what they do is that it's mandatory, mostly in the US and probably in other parts of the world as well, to give a vitamin shot, and it's a pediatrician would do. Okay, so it is always good to know because you're dealing with a procedure which might involve bleeding. So you want to make sure that vitamin K shot was given at the time of birth. So we did that. We confirmed with the pediatrician that she had taken vitamin K shot. Behavior. So how do you handle a 3-day-old baby in the dental chair? And the papoose boards or the restraints or doesn't apply to just born babies. Those are meant for like young children. So behavior was something that was challenging that you need to know. And we discussed the treatment options with the parents, and there are different ways of doing a tongue tie release, surgical thing, which is with a surgical clip, but that might require doing a procedure in the general anesthesia, or even in the normal setting. It's very difficult to do sutures because of the behavior. So we decided to do the procedure with a soft tissue laser. So we do have a laser, and I teach my residents on doing a lot of surgical procedures. It's fantastic. We do like mucocele and soft tissue, and it's a soft and hard tissue. It's yttrium YAG material. So, but again, it's useful for both like doing soft tissue and hard tissue procedures. So you see how little the baby is, right? So it just occupies a very minor portion of the entire dental chair. So we had to, the most important thing with the laser is that because of its ability to penetrate things, so you got to be very careful that you wear the appropriate attire, your goggles and things like that. And you have to restrict the number of people coming in and going. You have to mark, these are the recommendations from the board, is that you need to also indicate, like I told you in the previous thing, as you see here, you need to post that sign outside that you're like when you're taking x-rays, you always kind of indicate that the x-ray machine is going on. So likewise, you need to post that danger sign to be able to let people know that there is some laser procedures going on, and use the appropriate goggles. And this is called water lace, which is done by, which is produced by a company called BioLace, and they have all the settings incorporated into it. So, and then we wrap the baby, cover the eyes with some gauze and some tape to ensure that we don't hurt the baby's eyes, and then wrap it around like that with some blanket, and then that is what we did. So it's a soft tissue laser, which means that it doesn't cause bleeding. It pretty much cauterizes the soft tissue. It cuts the tissue at the same time it cauterizes the blood vessels. So that is what you see earlier, and this is after this thing. You see that's a beautiful diamond shape. That's what we say, because of the, once you release it, it forms automatically, it forms a diamond shape shaped cut here. So that's the after the procedure. The immediate post-op, so there was no bleeding, as you see here. This is after the release. Immediately after, there's not even a drop of blood coming out because of the laser. And then, the mom was able to immediately latch, the baby was able to immediately latch and start feeding. So mom was happy, baby was happy, and she wasn't crying anymore. So that's the last patient. I think we are on track with the time. We have another 4 minutes. This is the last slide, I believe. What is the hardest, let me see the question. What is the hardest thing about being a dentist? It isn't hard at all. I mean, it's not hard as you might think. It's, if you enjoy what you're doing, every day is awesome. So, but the challenge, I would say, is particularly with me, is that I got to juggle between my teaching and practice, because as I told you, I have my private practice. I do teach. I take pretty much, I direct the research for the entire program, department. So managing with all the research commitments within for my residents, as well as reaching out, my own personal research with the collaborations, as I told you earlier, that's a bit of a challenge, but mostly I do research on my weekends, so I don't really mind, The most important thing as being a dentist is that you have to have a very good work-life balance, It's not about just working, it's just not about making money. You need to know how to enjoy life as well, okay? So my one last suggestion, or my little thing that I want to tell you all, is that be happy with what you have and enjoy every moment. That's the zest of life. With that, thank you, everyone. I don't have any more slides present. Question and answer. Yeah. So if you have any questions, please shoot.
Okay. Thank you so much, Dr. J. It was a very informative presentation. And because of the time that we have, I'm just going to pick 2 questions. First question is, as a faculty, what will you say is one of the best things about Virginia Commonwealth University?
Oh, that's a very interesting question. That's a question they asked me during my interview here, by the way. It's a great program. It's a well-established program, very, very strong in clinical. We do have a lot of things established in the hospital. State of art clinic. We have CBCTs, we have laser. My residents learn a lot of things in clinics, in the operating room, with sedation procedures, and so it's a great program. We do have an amazing facility. The faculty are they're knowledgeable, well-known. They're always inclined to teaching residents. So it's a great program.
Thank you. And the last question, will be any advice for international trained dentists when they are applying to dental schools in the US?
Oh, I think I went with that thing. As I told you, myself being an international trained dentist, international trained pediatric dentist, it's always challenging. So, I mean, right now the situation is very difficult, particularly with the COVID. You know, a lot of my friends, even like with a lot of credentials, they have difficulty even getting an interview because I was told by, I mean, VCU doesn't take international candidates, but I was friends with a lot of program directors all over the US, and I was told that they take international candidates. I was told that they have difficulty getting them in because of the whole COVID, embassy, visa. So they aren't very sure, like even if they really like a candidate, how much they would be able to get their requirements to be able to come to the US. But I hopefully, fingers crossed, the COVID situations get better and then they open up the windows. But my suggestion is that just be consistent, get all your basic requirements sorted out. And as I told you, don't hesitate to take a risk.
Mm-hmm.
Don't hesitate to contact people. Don't think that I'm just an international person that would not reply. No, not at all like that. I mean, yes, people are always busy. Academia keeps them all busy, but there will be like one or two people who would still reply to you. So keep that hope up and then just like keep trying.
Mm-hmm. Thank you so much. I think that's all the time that we have. And if the viewers have questions, they can send an email to you. If you're
did I put my email address in there? Can I put in the chat section?
Sure. I'll put it there. And that's it. And for the viewers, we have a small quiz for you to do. So remember to do it before it get expired within 24 hours. And that's it. Thank you.
Thank you very much, Claude. See you all. Thank you. I really appreciate spending your